Good morning, good afternoon. Thank you for joining us for the National Collaborating Center for Determinants of Health webinar today called Addressing Inequity and Abuse in Long-Term Care, Implications for Public Health Practice. We're really pleased and excited that you've joined us today. My name is Claire Betker. I'm the Scientific Director for the National Collaborating Center for Determinants of Health, and I'd like to start by acknowledging the land that I'm providing these greetings and opening this webinar. I'm in Treaty 1 territory, which is the traditional territory of the Anishinaabe, the Cree, the Oji-Cree, the Dakota, and the Dene people, and the national homeland of the Red River Métis. So welcome. Bit of housekeeping, just as we get going here. There is French interpretation available today, and you can access that. If you look at the bottom of your screen, there's a globe there. If you click on that globe icon and then select the language French, you can see the picture in the slide. You'll be able to hear the interpreter who will be interpreting the webinar today. If you click it again, you can also mute the original audio and all you'll hear is the interpreter. So I invite you to do that. There's also English closed captioning available, and you can access that by clicking on the CC, sort of right to the left of the globe, the CC button at the bottom of your screen, and then you'll see the closed captioning. Our conversation today will be recorded. It'll be shared with those that registered. We had over actually 200 registrations to the webinar today. We're thrilled with that. So it'll be shared with all of the registrants, including you, via email after this webinar. But it'll also be posted on our website for future reference if you want to view it with your team or you want to share it with people who are unable to attend today. There's a whole collection of recorded webinars there. I'd like to point out the chat box at the bottom there, and I'd really like to encourage you to use that chat box right now if you want to introduce yourself, your name, your land acknowledgement, if that's what you would like to do, and where you're from. And we'll also use the chat box for questions. You'll also see resources. Some of our NCCDH team will be there, and they'll be putting resources in there. You can also share your own comments, your own stories, your own worries in the chat box. So please use that. And also, as I said, please use it for questions to our speakers. We have some really esteemed researchers with us today, and I know you're going to have questions. And you can ask those questions in French if you'd like. Our staff or our team will help to translate it for those that are French speakers and want to ask the question in French. And then finally, at the very end of the formal part of the webinar, there'll be an evaluation that'll pop up, and we'd really like it if you could answer. It won't take very long, a few minutes. And offer your feedback on the webinar today. Okay, so I'd like to start now with a land acknowledgement as to where our center is. The center, the National Collaborating Center for Determinants of Health, it's located in Mi'kmaq, which is the ancestral and the unceded territory of the Mi'kmaq people. And that territory, I'm not present in that territory right now, but our team is there and our center is there, hosted by McMaster University. That territory is covered by the Treaties of Peace and Friendship, which the Mi'kmaq and the Wolastoqiyik peoples first signed with the British Crown in 1725. And they did not deal with the surrender of lands and resources, but in fact, recognized and continue to recognize the Mi'kmaq and the Wolastoqiyik people's title, and established the rules for what is now an ongoing relationship between nations. So the National Collaborating Center for Determinants of Health is one of 6 collaborating centers funded by the Public Health Agency of Canada. We were established as part of the public health infrastructure post-SARS. So all of us at a few different starting points, but in and around 15, 16 years ago. And our job, our role is threefold: to establish networks, bring people together. That's why I'm asking you to engage in the chat and engage with each other. So helping people to find each other and to network across the country. The other function of the 6 collaborating centers is to identify knowledge gaps and to work to fill those. And then the third one, which is we're here today, is to offer products and services like a webinar, like a workshop that works to get the evidence, whatever that evidence is. In this case today, it's research evidence, but sometimes we have lived and living experience, community organization experience, that evidence in multiple forms in the hands of those that make decisions. And those decisions, of course, are at the point of care, but also at team, organizational level, and all the way up through to the policy system. So that's who we are, and we're really excited to be here today. So our objectives for the 1 hour we have together is to take a look and describe the trends in resident abuse among long-term care homes, in particular in Ontario. To discuss and to think about the impact of ageism and what that has on access to equitable care. Explore the implications of, I think, some of the very startling research findings that are going to be presented to you today. And then to think about and highlight what's the role, or what is the potential role, of public health practitioners and decision makers across the country in addressing this really serious issue. So I'm going to introduce our speakers, and they're spotlighted on the camera for you. But we have 2, Dr. Andrea Baumann and Dr. Mary Crea Arsenio with us today. Okay, I'm going to introduce the speakers, and then I'm going to do 2 polls as we get you engaged here, because I started that. So Andrea Baumann is the Associate Vice President of Global Health in the Faculty of Health Sciences. She's also the Director of the World Health Organization Collaborating Center in Primary Care and Nursing Health Human Resources. She's made substantial contributions, and I remember hearing about Andrea Baumann actually as I moved into management and into work at the NCC many years ago now. She's made many substantial contributions as a health services researcher, as a writer, and as an award-winning academic. Amazingly, she's got more than 200. That's just almost beyond your imagination, peer-reviewed publications, and she's written and contributed to several books. And her focus has been on employment, integration of internationally trained nurses, which we know is the largest predominantly female group of highly skilled newcomers to Canada. And she was inducted into the Order of Canada in July 2018 in recognition of her accomplishments. Mary Crea Arsenio, Dr. Mary Crea Arsenio is a senior research analyst, also in global health, Faculty of Health Sciences at McMaster University. She is also a health services researcher with expertise in migration, health policy, employment integration, and health human resource planning, something that is super critical right now in post-pandemic. Her recent publications focus on the impact of COVID-19 pandemic on long-term care, including neglect and abuse, social isolation, and excess mortality. So that's who our speakers are. So let's find out a little bit about you, our audience. And we've got 125 people here. So if you look at this slide, you can either go to slido.com and punch in that number 3025463, or hold your camera up to the QR code and it'll let you into this survey. And we're just really interested in who's in the room. So the poll will help us to see who's in the room. Looks like we have 11 out of the 126 of you. So I'm just going to give you a few minutes to push that up. We're sitting at 20 now. Interesting. Public Health Frontline. And like I said, the National Collaborating Centers, all of us, National Collaborating Centers for Public Health, were our audience, we were sort of designed and created to really focus on public health and the public health workforce across the country in the public health systems of systems that are out there. So it's really good to see that, a quarter of you that have responded so far are actually at that front line of public health, and another quarter in leadership, medical officer of health, or decision makers. Yeah, so almost 50, more than 50% there. Okay, just looking for people to find out how to interact with us and how to respond. So we've got some researchers here, some from long-term care. That's great to see, and some from government. Okay, so the next slide is going to help us build a word cloud. So what we're going to ask you to do is, what is one word that comes into your mind when you think of, when you read the title of this webinar, Addressing Inequity and Abuse in Long-Term Care, Vulnerable, Implications for Public Health Practice. Researcher, neglect. So as you push in your one word, it's neglect, harms, dignity, safety. Oh, interesting, systemic racism. So really pushing out some of those structural determinants and structural drivers of inequities, marginalization, Indigenous people. Nice. Let's see if we can get it up around 70 here. Overlooked, systematic, which matches the definition, or the description of inequities or inequity, when it's systematic. Racism and colonialism, ageism, and then some of the issues, a lack of staff, health, fear, outbreaks, overlooked, underfunding, urgent, sad, yeah, isolated, caregiver burnout, yeah, overdue. I really agree with that one, overdue. Almost like the system's neglected the issue as well. Overlooked, underfunding. Okay, great, thank you. I think, Andrea and Mary, that gives you a bit of a glimpse into what this audience is thinking about and what they'd like to hear from you. So I'm going to turn myself off, and I'm going to hand this over to Andrea and Mary, and I'm going to sit back and enjoy listening to your presentation of your research. So over to you. Thanks.
Thank you, Claire. It was very interesting to see the word cloud and the many adjectives, and I was pleased to see overdue, because what you'll see from this presentation, this isn't an issue of the pandemic. It probably has been an issue for a long time. So hopefully people will find the presentation interesting, and it's very nice to see key peoples of the public health unit, community, long-term care, etc. See everybody on the line, and we're very interested to hear your perspectives. You don't have the chance this time, but please keep in touch with us. Next slide, please. We weren't changing our, okay. So this is just the land acknowledgement from McMaster University. And for those of you in our region, we're from the Mississauga and Haudenosaunee nations, and the lands by dish with one spoon, one palm agreement. So thank you. Next slide. So how did all this start? As Claire said, we are health services research. We have done a lot of work in inequity on a lot of fronts: human resources, full-time employment for nurses, nursing, both cadres of nurses, issues of marginalized employment for PSWs. So we do a lot of work in equity and looking at how to make a system fairer. But in this case, it's a little more serious because it's not fair. It's about how to make it safer, just as a very first principle. There were, during the pandemic, several researchers from U of T, some of them you'll recognize, Reza Deber, Whitney Berta, Audrey Report, and from University of Montreal, who joined us. And we wrote a grant, and we're fortunate we were sponsored by the granting agency. And I would encourage you to look at that special issue. It goes in more depth in many of the issues in long-term care than we have time today. Next slide, please. So some of you will know this. We are focused in Ontario, but we do look across Canada and take deep dives in different provinces. But this shows you there are a lot of institutions of long-term care in Canada, and actually it's growing, and that's both the good and bad news. I think people need services. I think the issue still remains, what should those services look like? But this gives you the bird's eye view. Next slide, please. You know, why do we have this issue? It's a very complicated problem, but certainly these overview. David Oldenburger, as part of the grant, he did a very serious literature review. Pretty well everything had been written in long-term care in 20 years. And so he did a document analysis, and you could just track it back to the early 70s when all this began. There's no doubt that there's an overall issue of accountability. One would argue lack of funding. People always move to funding, you know, as an issue. Although we're now doing some work in exemplars, which we will talk about at the end. And the exemplars we're looking at do not receive any more funding. In fact, may receive less, depending on where they are, and they are exemplars. Physical infrastructure was focused on very much in the pandemic. You know, you may have read the, you know, people who were in more than one room and were more prone to infection, etc., and so forth. Again, it's important. One's physical environment is always important, but it may not be. It's not the only issue, as we know. Leadership is the one we really have landed on, to be perfectly honest. And as Claire said, leadership at all issues, at all levels. You know, the leader within the individual person, right up the line to who owns the facility, whether it's municipal, whether it's private, et cetera, and so forth, whether revisions, et cetera. This is one of the predominant factors in some of these issues. And of course, you know, we will never leave out staffing shortages because, again, people who work in this sector know full well or are very aware of some of the issues that they're struggling with. And for sure, it's certainly lack of help in many cases. Next slide, please. The way long-term care or the long-term care homes, it's pretty similar across Canada. There's a distinct legislation, can sit in the Ministry of Health or can sit like Ontario that has its own Ministry of Long-Term Care. There's a series of regulations. We all know as health professionals in every province, we have our health professional regulations in each province. And then there's standards. And standards have been around for some time. There are standards in the accreditation framework of Canada. And just recently, as you know, there was a group in Canada that spent many months developing really an excellent set of standards that are available as sort of a guide to all homes. Next slide. And again, this is the accountability for prevention of abuse, when we're going to focus today on that one particular aspect. And it's issue for what, and there is again, legislation that does address it and talks about compliance. And it's directly focused on staff of long-term care, the leadership within long-term care, and also the different ministries in the provinces, and in our case, it's the Ministry of Long-Term Care. And to whom, definitely, it's the residents and families, issues of abuse. There are issues of abuse of staff to staff. We didn't focus on that. You'll see in this slide, we focused only on one aspect of abuse. And then how does one ensure compliance? Well, in Ontario, it's definitely by inspection. And those of you in public health, some inspectors may be on. I began my career as a public health nurse, and I worked very closely with public health inspectors. In this case, I'll use our province as an example. We have specially educated inspectors coming from the province that are delegated to go into homes when there are incidences. Next slide, please. And then what happens? Again, we'll use Ontario as an example. But when you go across Canada, similar sanctions are there before you get into the criminal system. These sanctions are more consequential in nature rather than criminal in nature. At the very peak of it, of course, is the suspension of home's license if it's egregious enough, and we'll talk about that at the end. Fiscal penalties, return or withdrawing funds, and administrative penalties. And then, of course, there's these legal penalties. In Ontario, there are several class action suits ongoing and have been ongoing for some time now. And in some rare cases, very rare cases, criminal charges. And then finally, publicity and public reporting. And public reporting, all our inspection reports are open for the public to read. And you'll see in Mary's presentation, that's what we use to extract our data. There's also media reports. So we followed the media closely for almost 3-year period. So we have all the incidences over a 3-year period reported in the media. And that was we only followed 2 Canadian newspapers, the Globe and Mail and the Toronto Star. Next slide, please. So now I'm going to actually hand it over to Mary, and she will lead you through the study, and then I'll come back in at the end for the discussion. Over to you, Mary.
Okay. Thanks, Andrea. I think everyone can hear me okay. So as Andrea mentioned, we began this research in 2020, shortly after the pandemic had begun, initially just to investigate the impact of the pandemic in the long-term care sector. As Andrea noted, there were long-standing issues that were well documented over time. And what the pandemic did was it exposed the existing vulnerabilities in the system. But what it also did was provide an opportunity for research to examine the extent and nature of some of these issues, which is where our studies sort of emerged. So the purpose for us was to examine abuse, neglect, and social isolation experienced by long-term care residents in one Canadian province. So we focused on Ontario, and that will be what I'll be reporting on today. We used mixed methods to evaluate what is occurring in the home and with the residents. And that included an analysis of an administrative database of inspection reports over a 4-year period, as well as document review of different documents, including, as Andrea mentioned, the media reports from national newspapers, a review of legislation, and also inspection reports from the administrative database. So I will present on what is 3 papers that emerged from this work. 2 are published in the special issue, as Andrea mentioned, which we encourage you to open that link. It's an open access special issue, so the reports are all available, or the articles are all available. And 1 is forthcoming in a paper that will be released soon on abuse. Okay, next slide. Jumped ahead a little bit. There we go. Thanks. So these media reports are headlines that are familiar to all of us and that emerged across the country. They're not exclusive to Ontario. They reflect, stark conditions in the long-term care sector exposed by the pandemic, but also many emerged after. So as things sort of settled in terms of the height of the infections and mortality as we got vaccines put into place, and we noticed a decline in the deaths occurring in long-term care, some of the reports eased, but not all. And as you can see, the most recent one we have here is a severe one in March 2023, so of this year. So these issues continue, which was important for us to note in our findings, because oftentimes we were approached with, oh, this is something that is new. It just happened because of the pandemic. But in fact, our analysis revealed that this happened before the pandemic and has now continued since that time. So as Andrea mentioned, we did an analysis where we looked daily and we extracted news articles that emerged from the pandemic beginning in March 2020. For 9 months, it was a daily extraction. And then after that, we sort of eased up a bit on some of the reports. But what we did find through the media reports was there were common themes that emerged that supported and what we did was we triangulated these reports with our other data sources in order to corroborate our findings and validate what we're finding, which is what we'll be presenting today. Next slide. So the other thing we did was we looked at Ontario's legislation in long-term care. It's called the Fixing the Long-Term Care Home Act. And under that legislation, there are definitions of abuse and neglect, which we've provided here for you. You can take a look at what those definitions are. What we did with these definitions is we used them to categorize our findings. And so we note in our results of our papers that the findings are based on legal definitions and inspector findings based on these definitions. They're not definitions that we created, and they're not definitions that came from the literature. They're directly from legislation, which isn't, for us, was important to provide that detail. So abuse is things that you would expect: physical, sexual, emotional, verbal, or financial. Under emotional is where we'll find social isolation, which we'll talk about in a bit. And then neglect in Ontario is considered separate and has given a separate definition from abuse. We did do a review and a scan of other provinces. Some provinces include neglect under the abuse definition. In Ontario, it's kept separate. Next slide. The other important thing for our study was the administrative database of long-term care home inspector reports. And again, this looks different across the country, so I'll explain what happens in Ontario. So in Ontario, the Ministry of Long-Term Care hires inspectors to go out and do investigate allegations of abuse and neglect that come from either a public complaint, so either a family member or a visitor to the home who's witnessed something and can call and complain, or through a mandatory reporting system of critical incidents. And critical incidents would include a variety of things, but for our purposes, we were focused on the abuse and neglect. So what happens is the inspector, an inspection is triggered through this system, and an inspector will go out and visit the home. The inspector does not have to give notice. They can enter the home and they do a full investigation. So they'll interview staff, they'll interview residents, and they'll go through documentation of the instance. And then they come to a final conclusion of whether or not there's been an incident of abuse or neglect. And they write this in a report, which then gets published on a publicly available website through the Ministry of Long-Term Care. So what we did is we took 4 years worth of those reports. We extracted the data based on key variables that were of interest to our study, and we analyzed that data to identify the extent and nature of abuse and neglect in long-term care homes from 2019 up to 2022. Next slide. So here's some data, very high level, data based on the annual reports. So the column called total number of inspections includes all inspection reports that were published. We took the full sample and then we extracted from that incidents of abuse and neglect, which is your second column. What we noticed over time was that in total, there were 12% over the 4 years of cases of abuse and neglect in terms of the reports, with a range of about 10 to 13% over those four time points. We did note in our papers that the data are an underestimation of cases of abuse and neglect because the reports themselves were varied in length and they included multiple incidents. Because of our resources, we counted each report as one incident rather than counting the multiple incidents within the report. So in this case, there is an underreporting. There's also an underreporting because we note that oftentimes an inspector will go in, they'll review and they'll go through different documentation, and they may note that there was an incident that occurred, but it falls under a different protocol or a different standard or guideline for reporting. And so it's not captured under the abuse sections of the legislation, and which I forgot to mention, there are two sections that we focused on. The first is the prevention of abuse and neglect, and the second section in the legislation is the promotion of zero tolerance, so policy to promote zero tolerance. So we only focused on those two sections, but we did note that there were incidents that came up in other sections under things like plan of care, which is a very broad area. So, you know, through an analysis of those reports in depth, we saw that there were other cases of abuse and incidents that emerged, but the inspector did not report it under that section. And so that was omitted from our data. So for these reasons, the data is showing an underestimation, underreporting of cases of abuse and neglect. Next slide. We also took a look by home level. So the first slide showed you the number of cases by report. This shows you the number of cases by homes. In Ontario, we have 626 long-term care facilities, and 62% of those had at least one reported incident of abuse or neglect. Of those, and that 62% represents about 385 homes. Of those 385 homes, 212, so 1/3 of the total sample, had 2 or more cases of abuse. And so what we found is that this is significant because it provides an understanding of, you know, how these homes end up in repeated, the slides are just flipping. Is it okay? So we're still here. Yeah. Okay. So yeah, so we tracked the multiple incidents of abuse because we wanted to know about these repeat offenders. And as Andrew mentioned earlier, those sanctions that are put into place don't seem to be effective when the same home is repeated over time. But what we did note is it's only about 1/3 of the total homes, and the sample gets a little smaller when you look at those homes that have 3, 4, 5 or more incidents. Next slide. So the other thing we did was we took a deep dive into the reports to extract themes based on our major categories. So the first one is abuse. I won't read the quotes here, but these are different examples of the types of abuse that were noted and recorded by the inspectors over the 4-year period. So these included physical. We also had cases of emotional and verbal, and provided some psychological as well. So I'll give you a minute to read those, and then I'll show you what the others look like. Okay, next slide. For neglect, we were able to categorize these further. So again, these are direct quotes that came from the inspection reports. I'll give you a minute to read them. But we were able to thematically analyze neglect because neglect falls under a failure to provide treatment. And so or to provide various things. So what we did was we categorized them into 4 main areas. It was a failure to provide treatment, failure to provide care, failure to assist or attend to. So things like if a resident was ringing a bell, that the staff member would not respond to the bell. So that would fall under failure to assist. And then failure to investigate allegations. So as I mentioned under legislation, the zero tolerance policy is meant for homes to have a policy and procedure in place for staff to report cases of abuse and neglect. And so if a staff member witnesses something and they don't report it, then that is also documented as a critical incident and put into the file. So that was one of the ones that we also counted when we looked at the neglect reports. Next slide. Social isolation was an interesting area of study for us because of, in Ontario, and I believe it happened across the country, there were visitor restrictions put in place where family members were not allowed to enter the homes for a period of time. We documented through our analysis 2 months where there were absolutely no visitors at all. By the time the summer came, visitors were allowed to come outside. But even in the media reports, there were those photos of, a resident with their hand on the window and the family member there on the other side of the glass. And so we've seen these reports, all of us have. And so we took a deeper dive into the media reports to extract some quotes and to look at what were the major themes in terms of the impact of those directives and the social isolation. And so again, take a read through the quotes, and I'll just let you know from our analysis, we identified some themes, things like depression, immobility, distress. Residents were visibly distressed. There was severe weight loss and unresponsiveness, a loss of function and overall strength. So the social isolation and those restrictions had quite an impact on the residents' health and their health and well-being. And these quotes reflect family members who spoke to media and provided this evidence, which we then analyzed further in our data. Next slide. So overall, I think the implications of these 3 studies, including our overall special issue and our future work, which we are still working on in terms of the abuse, I would say that our findings do build on existing literature that has very well documented the issues in long-term care. What we've noted over time is that there have been some improvements, but they are not, we're not seeing the impact in the data as yet, and also through other stories and visits to different homes, which Andrew will talk about. We've also identified that there are still issues that are there. So I think for us, the major implication and the takeaway from our research is that we need to prioritize solutions that change the dialogue and that recognize that one case of abuse, neglect, social isolation is one case too many. So what I'll do is I'm going to hand it back over to Andrea, and what she'll do is she'll talk a little bit more about the implications and the contributions of this work. And then we'll take questions after. Andrea?
Brief thank you, please. I think the implications of the findings, in the next slide, please. So this is an issue that it's hard to really discover what is the root cause. Many people protect residents, the staff who are working with them, nurses, physicians, allied health, social workers, inspectors, definitely the personal support workers who are in long-term care. And many organizations are involved in equity and
Andrea, something seems to be blocking your sound there.
Oh,
That's better. That's
Yeah,
better.
before the pandemic, before the pandemic, Ontario was decreasing the number of inspections, moving to phone inspections. But of course, since the pandemic and during the pandemic, it became evident that to reinstitute the inspector's personal visit to different homes when required. Public health is interesting in terms of we have not done a study of the role of public health. We do know, of course, their role in many aspects of health and equity, population health, infection. They played a key role, obviously, in the pandemic. And that's really why we're here today, is sort of to discuss what the present role is and what the future role could probably be for public health in this area. Next slide, please. Again, where does public health fit in? Many people on the call would be probably more suitable than myself. We just looked at issues of equity and recognized, the big role public health plays in equity and healthy lifestyles and disease and injury. And also public health plays a really interesting role, still prevalent, even when I was a public health nurse, with family violence and children and families, which is interesting. And we just highlighted PHAC Family Violence Initiative that's available on the web. With regard to long-term care, public health plays a very serious role in terms of infection and prevention and control, immunization, vaccination, issues of hygiene, issues of breakouts still to this day, flu and COVID, public health units at the local levels, staff going in and advising on protocols in terms of prevention of infection. And there are many more. These were just to highlight for discussion. Next slide, please. And again, who are the priority populations? Again, it's a keynote of the Public Health Agency. The priority populations, again, increased risk of poor health outcomes due to burden of disease or factors. Determinants of health, including the social determinants. So it's broad, and this is right from our Ontario Public Health Standards. Many talk about ageism in terms of the issue of long-term care. Definitely the population in long-term care are older. There's no doubt about that, but they can be as young as 44. It depends on their issue of where they need help and where the local community services are. So yes, it is an issue of ageism, but I think it's a more fundamental issue. When you have abuse, it's what is the issue behind abuse, complicated. Next slide, please. What is happening? Well, again, the government has, the pandemic, as we started out to say, the government has definitely increased the number of beds. In Ontario, they're building new facilities. There's more training programs for personal support workers. They've increased or will increase the hours of care, and that all this will help. They've amended the legislation, and they have certainly increased the number of inspections and inspectors. So they are trying to move beyond the minimum. The most startling thing we have to say is the problem still persists. And we continue to say that because I'm looking at the data. It's not going away, but at least these are positive directions. Next slide. What we began to think about as researchers, what could we do about this? And we have now focused our work on exemplars. There has been some very good early work pre-pandemic done by a number of investigators in Canada and in Ontario. And there's a number of organizations trying to highlight issues of care But again, what do exemplar organizations, what did they do during the pandemic, and what are they doing after? And as we said, the one thing we noticed at the facility level is definitely effective and involves leadership. And we do have an article we did publish in that journal relating to that. We saw in the pandemic, the organizations were nimble, rapid assessment, anticipatory decision-making, and early detection. So they moved quickly. They moved in January. They didn't wait till March. And they definitely had a very team-based approach to staff. It was quite consistent in the ones we studied, and clear and consistent communication, and leaned heavily on the resources within their own community. And those organizations today, this is an ongoing study, continue to do that. They're very well connected with their local hospitals, with their organizations, and again, very concerned in terms of quality of care. Next slide, please. So we don't have a lot of time today. We really would like to have more of a roundtable with everyone on the call. There isn't the time. We just today we presented the data, some final thoughts, but we're interested very much in people's thoughts or what you think the way forward is for this problem. Abuse is a multi-jurisdictional problem. Many people are involved. And many people are trying to improve the system. There is definitely, no doubt, and that might be my bias, my early bias from my early career, but I don't think it's a bias. I think it to be true, that there is recognized expertise in public health in protecting vulnerable population. And I must add, there's expertise as well in inspection, even though, again, the inspections have a different purpose. And then again, looking at the FACT Family Violence Initiative for Children and Families, it's quite powerful and very interesting. And again, maybe, this sector needs something focused like that, and just leave that as a final thought. Next slide, please. So again, it goes back to these rather large principles of accountability, and it is an issue of equity. Equal care for all citizens in our population, and it's definitely an equity of social justice. Sometimes, again, if it is an issue of abuse, it's an issue of criminality and protection of the public. And again, it's an important issue. And for those of you online that are probably on the front line, I'm sure you have your own thoughts about it and some excellent ideas of what you might need to address this really important issue, or what you've observed and what you think might be effective. And I think that's where a lot of the answers lie. They do lie in those that are trying to care for people in long-term care, but they also lie with health professionals, and they, in terms of the health professional standards, as well as they lie at the door of governments often. But somehow the system doesn't work together in a consistent, coordinated fashion. The one thing we know in terms of the consequences of some of the long-term care homes in our province, we studied that. We've got that tabulated. Maybe they get a $5,000 fine and they carry on. We know full well you can't close down a home, like you can't close down a hospital. It's just impossible. So what is the solution? Why do we have recidivism? And why is it allowed? These are the existential questions that I think we're both trying to answer by research and trying to help clinicians in the field apply solutions to the issue. So I'll leave it at there. I know there's probably quite a few questions, and again, apologize. We haven't left a lot of time for questions, but we certainly would be willing to get back to you. So we'll leave it for a few questions now, and I'll pass it over to you, Claire.
Yeah, thank you. Thanks, Andrea, and thanks, Mary, for that really interesting. I know that was a number of studies, and the one that you reported on here is a large study, so it's always a challenge to do it in a short period of time, but you did a great job. Yeah, someone's thanking you for the excellent and insightful presentation. Thanks, Diane, for taking the slides away. And maybe somebody, one of the team could put Mary's and Andrea's information there with their email in case there is someone who'd like to reach out to them directly. And there are a few questions that that are in the chat box, and we have about 10 minutes, so that's quite good. So I encourage people to continue to add their question to the chat box. The first two questions that came in really talked about the inspection, and Mary, you spoke to that. So they asked, was the inspection conducted making the staff aware of the inspection? And was there difficulty getting access to the inspection report? Those were two questions asked by two different people, more of a logistical operational question.
So the inspection reports are publicly available. So in fact, that's not a barrier in terms of extracting the data. However, we did note when you have an administrative database or online repository, such as those reports, they're not user friendly, and they're not, for the public to just go in. Yes, you can pull a report by home, any year, and you can take a look at that report, but it is hard to sort of dissect, what the reports are providing in terms of the information. So I think to the second question, it's yes, their reports are publicly available and you can easily access them, and that's how we access them. The first question was, are the staff aware? Is that?
Yes. Yeah.
Are they aware coming in? Yeah, I mean, they speak with the staff as part of the investigation of those involved, the director of care. I mean, there is information provided, prior to the full investigation that they're coming, and that's what the process that will occur during that period. We also did note that some investigations were a day, some occurred over a week or longer. And I think it just depends on the cases and the incidents that they're investigating.
Great. Thanks for that answer. So the next question is around personal support workers, which are critical in long-term care residents, long-term care facilities. So has the study included the challenges that personal support workers face from their perspective? Like, did they actually talk to them? And if yes, could you share some of those findings that are relevant with a public health point of view? So kind of asking you to take that public health angle on what they heard in terms of challenges from the public health or the personal support workers' perspective. And I know you have a whole study on what I would call kind of decent work relative to personal support workers. So you might want to speak to that a little bit as well.
The issue of personal support workers and registered practical nurses and registered nurses who work, and many of the personal support workers are at the bedside. That issue is very well documented, and some of the workforce issues they have, and the hours of care they're allowed, and the number of, which is absolutely striking, the number of people they have to take care of in a day. It was up to 12, down to 8. 8 is still too many. People need care. They need personal attention. And it is a mistake to swing from this issue to a staffing issue. It's adequate support for staff, for education, training, and also an openness to listen to their concerns, forums where they can talk about their concerns to administration. There's no doubt that would go a long way in helping both the staff and residents. So as I said, that we think that is certainly one area, but it's not the only one. Again, that's where the leadership comes. Mm-hmm. It's up to the leaders to not only obviously they'll support the standards, but they have to become advocates within their own institution if they think there's poor staffing. And it's difficult. It's a difficult sector. It was made more difficult by the pandemic. Personal support worker has certainly been well documented. And I think probably the main people to in Ontario get clients to have more time for care. And it was up to their advocacy that did that, as well as others, of course, you know. But a lot of good documentation there. They have a difficult job for sure.
Yeah, thanks, Andrea, for that question, or for that answer to the question. I'm going to ask the question that was, you know, as we prepared for this webinar, that was really sort of top of my mind, and that was around policies. You know, what policies could support, and in this question it says proactively preventing abuse. And then there was another question that I think has a policy implication to it. And that is, did you find any correlations between neglect and factors such as race, socioeconomic status, et cetera? So to me, then I start thinking about, you know, how data is gathered, whether it can be disaggregated, what are the policies around that? So Mary, Andrea, do you want to sort of think about the policy, and then really, could you make a correlation? Like, did you have the data that was there? Is the data available to make those kinds of correlations?
One of the issues, again, who is in our long-term care institutions, you know, what resident of the residents, that varies from setting to setting and rural versus urban. There's definitely, it's definitely much more multicultural in a really large city. You have almost many cultures represented, both as residents and staff, by the way. There's no such thing as homogeneity in terms of residential characteristics. Issues of race, it's again, they don't collect that data per se. So, I mean, you can, from your own observation, make assumptions, but ageism probably supersedes it, I would say, in our observation anyway. And what was the second half of the question?
Around, well, that was around data, but around policies. So we got just a couple of minutes here. So Mary, do you want to have that final word on that question? There's a couple more questions in the in the chat box, but we'll maybe send those separately, and they're about racism. So yeah, go ahead, Mary.
I think for the studies that we presented today, there are other data sets that do resident level data, but it looks at like health outcomes. So that not abuse and neglect. I think our current best source of data for abuse and neglect is the inspection reports. Those reports don't identify residents by race, ethnicity, SES. So we have that information. None of that information is available for us to calculate those correlations. So our analysis was report level and home level based on the available data. But it is an interesting question. And just as Andrea said, the data is not available where you could link individual characteristics with cases of abuse and neglect within the institution.
Yeah.
And I think this is a big question that James is asking here, is how is racism being resolved or prevented in these homes? I'm not sure that you investigated this, but if so, so how is it being resolved or prevented? And if so, who investigates those activities? Is there an entity that actually would do the investigation there? I think is what James wants to know.
One of our early work with internationally educated nurses, we also used to say that your staff has to match your clients, and there's been some good work in that your staff represent that you are caring for. And I have to say that communities have come a long way on that there are staff members who would represent a socio-cultural ethnic background that that the residents are from, and that's a very important care principle. Not a policy, it's a principle of care. And top of mind before the pandemic. As Mary said, we can't get that there were attempts to, again, have hire staff who, again, would have, because of the very nature of their own background, have an inherent understanding of the residents, where they came from, some of their past, definitely their language. Language is key.
Thanks.
So
Thanks.
that was a bit of a news story. Mm-hmm.
Yeah, thanks. There's
Yeah.
some really interesting comments. There's some very interesting description of the challenges which you articulated in the early part of the webinar. So thanks everybody. Thanks Mary. Thanks Andrea for your hard work and for your research. Thanks for your excellent presentation. That evaluation is going to pop up. It'll also be sent to you, and really ask that you provide us with the feedback. And thank you everybody. Bye now.
Bye. Thank you for coming on. Appreciate it.
Thanks again. Bye-bye.